On behalf of the American Heart Association, I would like to welcome you to today's webinar, Hypertrophic Cardiomyopathy Series, Part 2, Clinical Case Study Reviews and Insights. My name is Bianca Presley, and I'm a program consultant for the American Heart Association. This webinar is part of AHA's Hypertrophic Cardiomyopathy Initiative, Advancing Treatment Decisions for Patients with HCM. AHA's HCM educational content made possible in part by a grant from Bristol Myers Squibb. Recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by AHA or ASA. The AHA-ASA does not endorse any product or service. I'd like to go over a few items so you know how to participate in today's event. To access live closed caption and presentations, please click on the closed caption button found on your screen. Throughout today's presentation, you will have the opportunity to submit text questions for our presenter using the Q&A feature on your control panel. You may send in your questions at any time, and we will review the questions during our Q&A at the end as time allows. If you experience technical difficulties, most user issues can be resolved by refreshing your browser. If you experience any technical difficulties, please contact System Requirements on the Zoom webinar helpline. At the conclusion of today's presentation, you will receive a link to access today's recording and an invitation to complete our feedback survey. It is my pleasure to introduce our speakers for today, Dr. Ankit Bhatia, Heidi Salisbury, Holly Andrews, and Dr. Ronald Wharton. Dr. Bhatia is an advanced heart failure transplant cardiologist and serves as co-director of the Hypertrophic Cardiomyopathy Clinic at the Christ Hospital in Cincinnati, Ohio. Dr. Bhatia has a specific research and operational interest in improving heart failure care through the use of remote patient monitoring. Prior to his arrival at the Christ Hospital, he completed an innovation fellowship with BJC, Washington University Healthcare Innovation Lab. He now serves as Director of Heart Failure Remote Monitoring at the Christ Hospital. Heidi Salisbury co-founded the Stanford Center of Inherited Cardiovascular Disease in 2006 and is the Program Operations Coordinator for the center. As a clinical nurse specialist, board certified in genetics, Heidi is dedicated to mentoring nurses, genetic counselors, and physician fellows to develop the clinical skills and gain the knowledge base necessary to adeptly manage patients with inherited heart disease. Heidi advocates building programmatic infrastructure that support a continuum of expert level nursing care through the individual lifespan and across the generations of a family. Heidi is active in leadership roles with the Preventative Care Nursing Association, HCM Society, and American Heart Association. Holly Andrews is a physician assistant working with the Hypertrophic Cardiomyopathy Clinic and the Advanced Heart Failure and Transplant Clinic with the Division of Cardiovascular Medicine at the University of Utah. In 2018, Holly joined Dr. Weaver Pinson as the physician assistant in the Hypertrophic Cardiomyopathy Clinic. In 2022, she joined the ongoing research effort in hypertrophic cardiomyopathy as a sub-investigator with the desire to advance therapy options for patients with this lifelong disease. Dr. Ronald Wharton is the director of the Hypertrophic Cardiomyopathy Program at North Shore University Hospital and also co-chairs the collaborative programs in cardiovascular medicine and sleep disordered breathing. Additionally, Dr. Wharton is active in the non-invasive cardiology lab at NSUH, where he interprets transthoracic and transesophageal echocardiograms and teaches subjects pertaining to this modality to the fellows in the cardiovascular training program. Dr. Wharton has been on faculty at the annual meeting of the American Society of Echocardiography several times. Dr. Bhatia, the floor is now yours.
Thanks so much. Let me go ahead and pull up my slides here and we'll get going. Beautiful. Hey everyone, my name is Longitudinal Journey. I'm an advanced heart failure transplant cardiologist up at Craig Hospital in Cincinnati, and I co-direct our Center of Excellence for HCM. So what's been beautiful about my role is I've been working at the intersection of hypertrophic cardiomyopathy and as it relates to advanced heart failure, which is my primary day job, taking care of transplant and LVAD patients. And I want to go through with you guys today a case that's close to my heart, a patient that we know well within the LVAD program here at Christ, and her journey, most of which we weren't involved in until the very last minute, as to a learning experience as to what we can do better to better recognize this condition and treat hypertrophic cardiomyopathy along the way here. So let's get started here. We have so our patient is a 48-year-old Black female. She's got a past medical history of progressive shortness of breath, as well as a recent TIA and new onset paroxysmal atrial fibrillation. This is back in 2016 when she was initially presenting to our regional hospital about 100 miles north of us in the Cincinnati region. So in terms of her past history, just purely hypertension and newly diagnosed paroxysmal AFib. In addition to that, she's got a mild smoking history, some alcohol use, but nothing substantial. Medications for her, just simply medications for both blood pressure and anticoagulation for her atrial fibrillation. She takes some Lasix as needed because she's had a history of swelling for several years thereafter. And family history, what's interesting about her is that she's got two brothers that had severely thickened hearts, and they're called thick hearts and characterized by physicians as hypertensive heart disease. But two brothers, and she only has 3 total siblings, and 2 of them were already diagnosed with these thick hearts, and all these siblings were in their 40s. So initially, we did some chart review and kind of went back to the outside hospitals and got some images from there. Back in 2016, when she presented initially with AFib, she underwent a cardioversion at that time. And at that time, you can see here on the images here that she had a severely thickened heart muscle already. And this is only at 48 years old. In addition to that, she'd already had some signs of ejection fraction reduction, EF, about 35–40% at this point. And she was diagnosed with hypertension, but really her blood pressure was only 130/80, so not severely elevated in that way. But at this point, this is what this diagnosis was called, and she was followed up in cardiology clinic. As you can see here, though, this isn't characteristic. This severe degree of hypertension is really severe and much more out of proportion for what you expect for someone who is hypertensive and relatively young in age. In addition, there's an effusion and other features that would make you think about a restrictive cardiomyopathy, but it was labeled as hypertensive cardiomyopathy at this point. So moving on, unfortunately, she clinically progressed. In 2017 and 2018, the patient ended up having multiple admissions for AFib with RVR. She required cardioversions 4 times over those 2 years. And in addition to that, she ended up undergoing a radiofrequency ablation as well, but still had recurrence of AFib. During these admissions, notably, her troponin and NT-proBNP levels would be elevated, so she would end up getting ischemic workups over and over again. She got a total of 3 coronary catheterizations during this time, and all of them showed no significant coronary artery disease. In addition, her metoprolol continued to get up-titrated during this time to help suppress these arrhythmias. And what she began noticing is that she's a highly functional person, a person who works as a civil servant. And really what she noted is that her shortness of breath became noticeable in daytime activities. She wasn't just noting symptoms when she had arrhythmias. She was beginning to note symptoms that are slowing her down in day-to-day life. So this prompted the physicians in the community that she was in to have her get a workup done. So she was referred to an academic center, not ours, but a different one at that point. And at that point, she ended up getting cardiac MRI. This ended up being 2018. And what that ended up showing is severe, now worsening, left ventricular dysfunction, severe wall thickening up to 2.6 centimeters. And as you guys know, hypertrophic cardiomyopathy diagnosed as over 1.5 centimeters, as well as extensive late gadolinium enhancement with low extracellular volume decrease, elevated T1 values, and really a lot of features that were really more consistent with cardiac amyloid, actually even more than HCM at that point. So at first with this workup, everyone was concerned about cardiac amyloid. And to tell you the truth, if I saw her first echo, I'd be concerned about cardiac amyloid too. And so we ended up, at that point, she ended up getting a technetium pyrophosphate scan, which is a nuclear scan that looks for specific components for ATTR cardiac amyloid, one of the two most common types, and that ended up being negative. In addition to that, she had screening with free light chains for AL amyloid, or basically amyloid that arises from the bone marrow. And at that point, what that ended up showing was elevated levels overall, but a ratio that really wasn't too far off normal. So really the team at that point was left in this period of ambiguity, and actually recommended an endomyocardial biopsy, which is very reasonable at that point. Unfortunately, this patient had been through so much. She had some distrust in the medical system, given how many admissions she had. And at that point, she opted to leave that academic medical center, not pursue further workup, and end up being labeled kind of restrictive cardiomyopathy, not otherwise specified. So in addition to that, unfortunately, she continued to worsen over the next several years. She ended up having numerous more admissions for AFib with RVR, multiple cardioversions, and 2 more ablations as well. And then finally, around 2020, her heart failure hospitalizations began. She was no longer coming in for AFib. She was coming in for fluid overload and requiring significant IV diuresis at that point. Again, all up where she lived. 2022 ended up being a bad year for her. At that point, she began noting in labs some progressive renal dysfunction, as well as some progressive hepatic dysfunction too, based on labs. Her albumin levels started to decrease. Her AST, ALT started to elevate. And because she kept having more AFib with RVR, she ended up undergoing AV nodal blockade and CRT, ablation and CRT. And by that point, her EF was 20%. There was moderate RV dysfunction noted, as you can tell here as well. And she began developing severe valvular disease, including mitral and tricuspid regurgitation. As you can tell serially from the echoes I'm presenting here, the EF really has just gotten worse over time, and you're starting to see the left ventricular cavity begin to dilate out a bit too, kind of showing this patient's kind of transformation from more of a restrictive thickened heart into more of a dilated phenotype. Finally, by 2023, she had really completely become NYHA class 3 to 4, really 4, frankly. She stopped working. She had lost over 50 pounds, but despite the loss of weight, she actually had worsening edema. So this is really more representative of cardiac cachexia, where she was becoming nutritionally deficient, sarcopenic, and really as a result of that, was losing body mass and muscle, but was gaining fluid. She developed bilateral lower extremity venous stasis wounds, given how bad her lower extremity edema was, and again, had numerous admissions at local hospitals. Eventually, she was transferred to our hospital, the Christ Hospital in Cincinnati, Ohio, and we met her for the first time in mid-2023. So in mid-2023, she arrived to us actually in the ICU, and at that point, we immediately did a right heart catheterization. That right heart catheterization showed elevated filling pressures, an RA of 19, a PA of 36/21 with a mean of 28, and a wedge of 26, which basically is a long way short of saying she had a lot of fluid on both sides of her heart. In addition, her cardiac output was severely decreased. Her thick cardiac index was 1.1 liters per minute per meter squared, and anything below 2 is really defined as low output that needs to be treated accordingly. So she was well below that at this point. So at this point in Impella, which is basically a percutaneous device that flows blood out from the left ventricle into the aorta, basically acts as a pump for the heart when the heart can't pump itself, was placed through her axillary artery in her shoulder area. And that device ended up pumping blood since the patient's heart could not. We use that device as a form of prehabilitation, basically a way of rehabbing a patient before considering a potential new intervention. And during that time, she was aggressively diuresed with IV Lasix and received dietary optimization as well as PT and OT. And here you can see basically the inflow of the Impella over here, as well as the outflow above the aortic valve. It sits in the left ventricle and above the aortic valve, and you can see that again here as well. And we use these devices commonly in advanced heart failure for treatment of shock, while patients list and wait for heart transplant, and as well as these situations where someone needs a form of support and you're determining if they're a candidate for LVAD or transplant as well. So in terms of her workup, we first started by considering a heart transplant workup We knew at this point this patient had a restrictive cardiomyopathy, and most of the time, the next best route is if you're in low output restrictive cardiomyopathy, we think about heart transplant, especially if you arrive in cardiogenic shock. What we unfortunately end up finding out is that she had a high degree of sensitization. We draw a lab called a CPRA, and that's a marker of how much antibodies a patient has in their body that may attack a donor organ. And basically, this showed with 85% that 85% of available organs would not be organs that would be amenable to her because she was severely sensitized. And anything over 50% is concerning. So already the donor pool is smaller. In addition, we ended up doing a biopsy of her heart, and that biopsy ended up showing myocyte hypertrophy with some fibrosis, really consistent with hypertrophic cardiomyopathy here, because the muscles were big and hypertrophic, and they end up having some signs that they've begun to kind of really burn out and turn into scar tissue. There was no finding consistent with cardiac amyloid on that. In addition, we ended up doing a liver biopsy just to make sure she wasn't cirrhotic, given how long she lived with elevated filling pressures. And that ended up showing some congestive hepatopathy, some mild perisinusoidal fibrosis and bridging fibrosis, but nothing substantial. And then finally, our infectious disease team felt that given her lower extremity venous stasis ulcerations, which were quite significant when she came in, she was going to be an infection risk. So her labs basically at this point, really hemoglobin normal, some kidney injury, which had actually been progressive. Her baseline several years back had been 0.8. And so her NT-proBNP levels high, indicative of her degree of heart failure. And then finally, her liver labs showing severely low albumin, normal was 4, we're down to 2.4, some mildly elevated bilirubin levels, and then finally some mildly elevated AST, ALT levels here, which should be in the 20s, 30s range, showing that she had some signs of liver-related congestion. So basically, together with all these features that we had found, it was deemed that a transplant would not be in her best interest, especially given her baseline functional status, and she was deemed not eligible for consideration. So at that point, we'd had palliative care meet with the patient, and frankly, when we first met her, the route that was being discussed was actually hospice care. But remarkably, she did very well with 3 weeks of rehabilitation in the hospital. She went from being completely immobile, requiring 3 people for transfers, to walking 50 feet with a walker. Her lower extremity wounds also fully healed with all that fluid finally drained off of them. But at this point, she was in low output heart failure with a low ejection fraction and no real exit strategy. So at that point, the multidisciplinary heart failure committee came together, and the decision was made with patient shared decision-making to pursue a left ventricular assist device. A left ventricular assist device, for people who are not familiar with it, is an implantable heart pump that actually sits in the left ventricle and pumps out blood into the aorta, basically a form of an impeller that you can go home with. You end up having a little controller, a driveline that exits the body around the abdomen area, and a patient wears 2 batteries to help to power it. This is a therapy that's proven to make patients feel better and live longer with end-stage heart failure, and it's a staple of any advanced heart failure program. She actually was felt to qualify for a left ventricular assist device because she had dilated out her heart slightly enough that a cannula could actually fit in. And I'll show you a picture of that here. So if you can see here you see the left ventricle, now you see this big metal thing fitting into it. That's the cannula, the inflow of the left ventricular assist device. So that was placed in because she had enough space for it. And many hypertrophic cardiomyopathy patients do not. So she was lucky in that way. So she ended up having this left ventricular assist device put in, and then was discharged home about 3 weeks later with a relatively very uneventful post-op course. She was set at relatively low speeds of her LVAD because her heart was small to begin with. So we didn't want to have the speeds be so high that we sucked in the interventricular septum and caused issues with suction and whatnot. And she did very well with that. At 6 months post-LVAD, which is roughly where we are now, she's been walking independently, and she completed cardiac rehabilitation. In addition to that, she sparked my interest as an HCM specialist when I saw her in clinic, and I was like, oh, wow, you've had, and we talked about her family history, multiple family members diagnosed with thick hearts and whatnot. So I ended up having her undergo genetic testing, and again, that confirmed the diagnosis of HCM because she was found to have one of the 2 most common genetic mutations, myosin binding protein C3. So we made the formal diagnosis officially. It was thought of, but we made it officially, of hypertrophic cardiomyopathy with LV dysfunction, or burnt out HCM, and therefore end up having cascade testing with genetics for her sister and daughter to receive genetic testing as well as the brothers as well. And since that point, the patient has excelled, and she's become a community educator for HCM and heart failure, and really a testament to what can happen when you treat heart failure that hasn't been treated for a significant period previously. So some takeaways from this case is severe left ventricular hypertrophy, or hypertrophy in general, should be investigated, especially in younger patients. Hypertensive cardiomyopathy is a diagnosis of exclusion. Don't blame things on hypertension until you've ruled out other infiltrative processes that could be causing this heart thickening that you observe for patients. When in doubt, and I see this a lot in my HCM clinic, a cardiac MRI and genetic testing can help to cinch a diagnosis of HCM or other infiltrative cardiomyopathy, including amyloid. And specifically genetic testing, not always positive with hypertrophic cardiomyopathy, but positive in about over half the time. So if it is positive, it helps you make a diagnosis in that direction, versus if this is positive for something else, Fabry's, amyloid, it can point you in that direction as well. Hypertrophic cardiomyopathy, specifically in Black patients, can be hard to diagnose. This is a population that has higher degrees of hypertension, lesser family histories of HCM, and the pattern observed in Black patients is more likely to be non-obstructive. As you know, 2/3 of patients with HCM are typically obstructive, but this was an example of a patient that never had left ventricular outflow tract obstruction. And they also tend to have more apical and neutral septal phenotype HCM, more specific and looking similar to what hypertensive cardiomyopathy would look like. So basically, it's more hard to tell it apart. And then finally, as you all know, hypertrophic cardiomyopathy is under-recognized in all populations across the board, but much more significantly amongst minority populations. And we need to do better with outreach and really reach out of families when someone in a community like this has a diagnosis that is made. Finally, our lessons learned. Hypertrophic cardiomyopathy is a heterogeneous condition, and in many cases, such as this one, can present more generically, just like HFpEF. It's important to find out what's going on as the underlying cause and have a clear diagnosis made. We can easily treat AFib to the end of time, treat some fluid over to overload to the end of time, but it's important to characterize a diagnosis because that can help you establish prognosis, therapy considerations, and family screening, which are all essential parts of treating a patient comprehensively. Advanced heart failure therapies should be considered early in hypertrophic cardiomyopathy. These are for patients that have had refractory symptoms and hospitalizations, heart failure with reduced ejection fraction. When the EF gets low in a symptomatic patient with HCM, that's a big deal. Hypertrophic cardiomyopathy is a condition where the heart squeezes more, not less. So an EF below 50% is something that needs to be addressed. And then finally, if a patient starts to develop kidney or liver-related dysfunction, cardiac cachexia, weight loss, these are all signs that their heart failure is worsening and they should be considered for advanced therapies. Referral to a heart transplant center specifically should be conducted early. A stable hypertrophic cardiomyopathy patient by current listing guidelines is able to be status 4, meaning that if you have someone with refractory symptoms and meds aren't working, that is good enough to get them listed unless there's another contraindication. They may wait months or more in the current system to get a heart transplant, but that is the ideal time. A patient getting a heart transplant with HCM, in my mind, should be someone that is walking into the hospital with symptoms, not someone who's crashing and burning and needing an Impella. And that is all I got here. Please would love to open up for questions and we can go from there.
Thank you, Dr. Bhatia, for presenting that case to our group on today. I do have a question for our panel, just to kind of get the conversation started about this case study and the insight. In thinking about the information that's been presented and some of the decisions that were made, based on your views of HCM care, what could have been done differently in this case? And are there areas of opportunity in the HCM care pathway?
Bianca, I think it's a really great question because, we can all sit back and think retrospectively, oh, well, I would have done that better and I would have done that better. I think the biggest thing is recognizing a diagnosis early. I think as a professional society that tends to favor procedures, it's very easy to go, cardiovert someone, very easy to go ablate someone but that's not making a diagnosis here. And had we known this was a diagnosis of HCM earlier on, and some of this was on, the patient as well to kind of help them make that diagnosis, we could have then had this patient be referred for heart transplantation consideration earlier. Infiltrative cardiomyopathies allow you an earlier means of getting a heart transplant by current listing guidelines than other approaches. So really all I would say is better recognition of the diagnosis earlier, an earlier referral to a heart transplant, and an HCM center of excellence as well. The other thing I'd say now is that we have so many investigational medications that are on the radar. Things like myosin inhibitors and whatnot, this patient was probably a little too far gone for that when they were diagnosed, have the potential of being disease modifying. We don't know that yet, but we have long-term data coming. And so when you have someone that's more severely sick when they show up, late gadolinium enhancement on an MRI, signs of heart failure when they present, that's someone that I'm pushing into clinical trials right now in some of these spaces. And that's why, again, an HCM Center of Excellence is something that should be considered early on in these patients.
No, thank you. Thank you, Dr. Bhatia. Any other thoughts from our panel?
I had a question for you, Dr. Bhatia. With an MYBPC3 gene mutation for that patient and the potential with the LVAD for the heart to continue thickening, what kind of observation are you guys doing? Is it differing from your usual LVAD surveillance with echocardiograms to look for thickening walls and problems with that LVAD, or just normal maintenance for surveillance for the LVAD patients? What are your guys' thoughts on that? Because it's a not unique, but fairly unique situation to have an LVAD in an MYBPC3 positive HCM patient.
Yeah, that is something that we totally need to consider. I think by this point, this patient is more developed, like more of the burnt out LV dysfunction phenotype. So if anything, the thickening has kind of gotten a little bit lower in the past several years. So I'd expect that process to continue, especially now that we're unloading the left ventricle so much better. Routinely, we do it yearly on a patient. But the beauty with an LVAD is that you're getting assessments of flow all the time. If you're all of a sudden getting flows that are reducing, anything that's concerning, you get pump alarms, PI events are changing and whatnot on the LVAD, all these little features we look at, that's a sign like, hey, we got to do something more urgently as well. Yeah, that's a good question. And if I had a patient that was 20 years younger that we had to think about an LVAD for, that's something we definitely would need to keep in mind.
I was also thinking about the opportunity to, pick this up earlier in the community with the primary care physician, not just knowing how to refer to a center of excellence and the importance of that, which was made, really well laid out in this example, but just how we support the greater profession, the primary care, the touch points where this could have been picked up in terms of, basic EKG or just such symptomatic hypertension, just different opportunities to improve the chances of early detection through our primary care system.
I totally agree. I totally agree that a lot of this has to do with community outreach. Part of being a center of excellence is not just sitting in your ivory tower and saying, oh, come to me. It's having us go out and do education. I know that there's also some AI related and more technology related features that are starting to roll out to help better detect here. But that's our role, is to really, really try to be more hub and spoke with this, really have champions at all levels that can help us better detect. Because it's not, you won't know you're missing something until you are aware that that's something you could be missing.
Yeah. Great presentation. Thank you.
Thank you.
Thank you, panel, and thank you, Dr. Bhatia. As a reminder, if questions would like to be submitted, please use the Q&A chat feature at the bottom of your control panel to submit those questions. And at the end of each case study, as well as the end of this webinar, we will address those questions as time allows. All right, right now we don't have any questions in the Q&A box, but we thank you, Dr. Bhatia, for your wonderful case review and your clinical insight. Now we will turn it over to Holly and Heidi, who will be presenting on HCM in pregnant patients.
Great, thank you guys. My name is Holly. I'm a physician assistant working with the Hypertrophic Cardiomyopathy Clinic at the University of Utah. I'm excited to be able to do this presentation with Heidi Salisbury, who's a nurse practitioner for Stanford Center for Inherited Cardiovascular Disease. This talk today actually started at the American Heart Association's scientific sessions back in the fall of 2023. Heidi and I were sitting together talking about the differences and the similarities in our centers for how we care for pregnant patients. And then we've now had the opportunity to be able to talk about it here on this platform, which we're excited about today. So hypertrophic cardiomyopathy comes in, for the colloquial phrase, many shapes and sizes. Every patient's a little different with their presentation. Every patient is a little different with the treatment that they need. And this is a lifelong thing, and it can happen at any point. It can develop any point during life. So there's a large spectrum of treatment needs that are required for patients with HCM, from patients who do really well and don't need any therapy, patients who need surgical approaches, and people who even need transplantation. For what we're going to focus on today is the patients who have HCM, who want to start a family, and what that looks like for the normal life process for them to be able to move forward with that goal. So the American Heart Association has some new HCM guidelines that came out in May 2024, just last month. Part of that is how to work with patients with pregnancy and HCM. My favorite thing to tell patients is, for the most part, most people with HCM do just fine in pregnancy. They tolerate it very well, and there's a very low mortality rate for the mother, which is wonderful news. Now, there are different exceptions depending on how progressed the disease is, but ideally, we would work with preconception counseling with these patients, and then have prenatal counseling throughout the whole pregnancy, and then talk about genetic testing too, so we can work on cascade testing for family members to see who else might be affected. In terms of these patients who are pregnant, and kind of planning through this pregnancy and what to do, we recommend that they all have an OBGYN provider. In a lot of cases, a maternal fetal medicine provider is preferred, as some of these can be high risk. And then we also really encourage coordination of care between the OBGYN and our cardiology teams throughout the pregnancy to be able to keep this patient safe. In terms of delivery itself, vaginal delivery is recommended as the first choice option, but obviously emergencies happen, or different C-sections, things like that need to occur. So the planning for it, vaginal delivery is the preferred method. General epidural general anesthesia or epidural can be used. We just recommend that hypotension is avoided. And then throughout the pregnancy, serial echocardiograms are reasonable, especially later on in the pregnancy. We would recommend that pregnant patients with HCM be seen at a comprehensive HCM center, or in some instances, a primary HCM center as well. Some very special considerations in pregnancy are those women who have HCM who also have AFib or develop AFib during pregnancy. Anticoagulation of some forms can be used. Cardioversion is reasonable, and beta blockers are okay, but we need to monitor for fetal growth throughout if they are on beta blockers. The other consideration is 2/3 of all patients have LVOT obstructions, and in the last 2 years, we now have myosin inhibitors. These are contraindicated in pregnancy, and so we need to, if someone is on them and they plan to become pregnant, you need to stop them well before, because they have a very long half-life. We also, for LVOT obstruction, need to be very careful for avoiding hypotension, and again, beta blockers are okay. So we're going to go over 2 case studies. The first one I'm going to present is more about the preconception counseling, and then the one that Heidi is going to present is about care throughout the whole state of pregnancy and the delivery process. This first case study, EB, she's a 29-year-old female, has never been pregnant before. Her and her spouse are ready to discuss having a baby. Her past medical history, she has apical variant HCM due to a likely pathogenic TNNI3 gene mutation. She has heart failure with preserved ejection fraction and hypothyroidism. She was first diagnosed at 18 years of age when she started having palpitations. Medical testing showed that she had HCM. She was diagnosed when there was family history they were going through. She had family history of sudden cardiac death, so she underwent an ICD for primary prevention of sudden cardiac death. She was first treated with multiple types of beta blockers, atenolol and nadolol first, and then ultimately metoprolol tartrate. She had significant side effects with all of these, so she's really struggled to be on medications for those palpitations. She was also started on a low-dose loop diuretic and potassium supplementation. And she was, prior to deciding when she wanted to be pregnant, she was on a hormonal birth control pill and levothyroxine. For EB, since being diagnosed at 18, it was a traumatic experience for her, having to live with these symptoms, having this idea of having a chronic heart condition, this ICD implant. It was really, really difficult for her. And so in planning for the future, she did not want to potentially have a child who had to suffer through what she suffered through from that emotional trauma with her own diagnosis. She was also worried about her symptoms in pregnancy. So she came to our clinic to talk about preconception counseling, and her spouse had already decided that they wanted to do in vitro fertilization to be able to have a baby without that gene mutation, without passing that on. So how we think about a patient who comes in with HCM and they are in this current state of, preconception counseling and what we tell them about pregnancy if they were to become pregnant with this disease. So for her unique things, again, she already has heart failure with preserved ejection fraction with fluid retention. And she already has symptoms with that as well. So things that we have to monitor for her are continued fluid retention. For all patients who are with HCM or considering pregnancy, education here is the biggest part. We tell them about inheritance. For her, she chose to do in vitro fertilization, but for all patients, we want to talk about the chances of the child possibly having HCM. For the most part, it's an autosomal dominant inheritance pattern. So 50% chance that all patients or all first degree relatives will have this disease as well. So any child could have HCM 50% of the time. We recommend at that point when we're talking about becoming pregnant, referral to a genetic counselor if it hasn't already been done yet to know if there is an identifiable gene. We talk about the risks of pregnancy. We talk about how most women with HCM who become pregnant do fine. However, we have to monitor it pretty carefully to make sure that it doesn't progress into not doing fine for these patients. So the ones typically who are symptomatic before pregnancy remain symptomatic during pregnancy, and it can worsen as it becomes a higher fluid state. We refer everyone to maternal fetal medicine. We consider all patients with HCM high risk and want them to be with that type of provider to start with. We recommend surveillance in our clinic. We do a clinic visit and an echocardiogram every single trimester. And if the patient starts to have more symptoms or anything concerning on the echocardiograms, then we increase that amount, especially in the second and third trimester. We always talk about then what to expect, one, during pregnancy, but two, also during the labor process. We tell the patients that vaginal delivery is recommended. We don't recommend home delivery. We recommend it at a tertiary care center. We let them know that epidural is okay. We just have to work with their team, their anesthesiology and OBGYN team, about trying to avoid hypotension in the setting of especially left ventricular outflow tract obstruction. We also, with preconception counseling, talk about any medications that they may be on that need to be stopped in order to be safe for development of that potential fetus. And then we also plan for close follow-up while they are thinking about becoming pregnant in that process, and then once they do become pregnant as well. For EB, she underwent IVF attempts for a year and a half, so April 2021 to October 2022. She was able to have a viable pregnancy, and she did really, really well throughout the whole thing. She established care with a maternal fetal medicine provider. Each trimester, we did an echocardiogram. They were pretty unrevealing and unchanging. In July 2023, she presented an active labor. She had an uncomplicated labor process and had a successful vaginal delivery the next day. Within 24 hours of delivery, she was discharged, and we saw her in our clinic 2 weeks later where she was struggling with some fluid retention. So we worked with her diuretic dosage to be able to help keep the fluid off, but also she was choosing to breastfeed, so trying to maintain milk supply. So overall, again, this was a very successful process of pregnancy, no complications, and really the highlights here were all the preconception counseling that we did. And then I'm going to turn the time over to Heidi, who's going to present our next case.
Thank you so much, Holly. All right. That was an excellent presentation, a thoughtful presentation where you had the opportunity to discuss pre-planning, pre-pregnancy planning, but a lot of us might be familiar with this example of receiving a call or message that says, "Hi, I'm pregnant." And this is a case of Miss BG, a 36-year-old woman, G2P1, presenting to clinic at 8 weeks pregnant. She has a history of non-obstructive HCM with a low normal left ventricular systolic function trend. She has a history of non-sustained VT, syncope, and a single lead ICD that's in place. Her genetic testing was unrevealing to date, and she's been off and on beta blockers, poorly tolerated, and yet when not pregnant, uses Lasix intermittently for lower extremity edema. Let me advance this slide here. There we go. Taking a look at her pregnancy history, BG's first pregnancy was full term, but it was complicated by systolic and diastolic heart failure symptoms, requiring diuretics post-labor and CCU surveillance in the coronary care unit. In addition, during labor, actually, she had a near syncopal event when she was given sublingual nitroglycerin spray, which actually is a fairly routine anesthesia intervention during labor and delivery. While she has an ICD in place, it's a single lead device, and there was a recall on her lead. When she was in hospital during labor, she was put on telemetry for symptomatic palpitations that correlated to slow non-sustained VT. On a follow-up device interrogation, that slow VT was not captured. GDMT was recommended after this first pregnancy, but deferred by the patient for breastfeeding. Looking at the trend in her systolic function is really important. As a hypertroph, as Holly pointed out early, you have all different types, shapes, presentations of the heart. She again is non-obstructive, but she just has something very significant here, which is her left ventricular systolic function back in 2018 sat upwards of about 60. Then over time, she has slowly kind of burnt out or had this reduced LVEF down into the mid 50s. And then during that first pregnancy, she dipped as low as 50. So now you're looking at a 10-point drop in her LV systolic function. There was some recovery after that first pregnancy where she sat around between 51 and 55. So how do we think about this case heading into the first trimester? Again, she's non-obstructive. Her heart is thick and stiff. Kind of think of her as an HCM PEF or an HCM with mildly reduced EF. Her LV cavity is enlarging. She has a little bit of this burnt out physiology, but still stiff with a high right atrial pressure and a chronically elevated NT-proBNP. And then on top of that, you don't forget about the fact that she's had that slow symptomatic non-sustained VT that what did correlate to symptoms during her last pregnancy and was not captured on her device. So in terms of action at this point, you really want to think about open communication, shared decision-making around maternal risk, continuing this pregnancy. And if relevant, have conversations now about therapeutic abortion. In her case, it was not recommended, but this is the point at which you would be thinking about this type of communication. If there is you need to be thinking about maternal risk and thinking about whether or not this is safe to continue this pregnancy. Really review and document her pregnancy history. What happens, the first go rounds? What do we need to learn? And what do we need to watch for moving forward specific to how she experienced pregnancy? And then establish a vigilant plan to monitor her cardiomyopathy and heart failure and arrhythmia peri-pregnancy. Consider medication management, stopping any fetal toxic medications, consider pregnancy safe medications, and of course, consider any such as beta blockers and changes in her anticoagulants if she were on them. At this point, it's really important to partner with high-risk obstetrics, establish a communication system, again, highlighting that from the get-go, you need to have shared communication between obstetrics, cardiology, and the patient that's documented and visible to everyone, and that you're able to build on as the pregnancy progresses. Know your guidelines, use your guidelines in partnership with the AHA and ACC. We have excellent guidelines here now for HCM and pregnancy. And then make sure to reference the resources available to objectively evaluate a cardiac patient's risk going into pregnancy. Here's some tools here: the risk prediction model, as well as knowing what your medications are that are safe during pregnancy. How to think about this heading into your second trimester. Really want to make sure you have a baseline pregnancy echo and EKG at about 20 weeks. The reason why we wait till about that time frame in a somewhat stable patient is just making sure the pregnancy is viable. And then at 20 weeks, we're moving forward. This is happening. And so if needed, update XioPatch based on the patient's symptoms or continue routine device checks. You might need to increase frequency of your device checks. If there are no obvious changes at the onset of onset of symptoms at 20 weeks, we monitor every 4 weeks through the remainder of the pregnancy. That not with testing, it's just a communication touch point every 4 weeks. Every 8 weeks, we look from 20 weeks on. Every 8 weeks, we do a baseline, a repeat echo and EKG, alternating with physician or advanced practice provider. And then at each touch point, we initiate and update the high risks, or we update the high risk OB cardiology shared documentation. If you're concerned for arrhythmias, increase the frequency of the device checks or send out a Zio. Start the communication now in the second trimester about breastfeeding and bonding. What are the options going to be for mom and baby based on what medications she may or may not be taking, and those that might need to be restarted post-delivery. And also introduce now the possibility that mom may need to be separated from baby when that volume shift happens with labor, should she have any signs or concerns of heart failure or be high risk going into labor, that she might be separated from baby and have to spend a little time in the coronary care unit for 24 to 48 hours post-delivery. Important to introduce that as soon as possible. And then heading into the second and third trimester and into labor and delivery, this is a checklist that is obviously needs to be very dynamic based on how mom is doing. But essentially, again, we have every 4 weeks a touch point, and every 8 weeks update the imaging and arrhythmia evaluation. We reinforce constantly through this process communication about breastfeeding and bonding, and the possibility of being separated from baby for 24 to 48 hours post-delivery. And we continue to work closely with OB, discussing possibility for future birth control preferences and planning is an important part of the documentation and communication in the second and third trimester. And then how do we think about this case through L&D and postpartum? We talk about rounding on mom and baby in hospital, again, reinforcing breastfeeding and bonding plan. And if needed at this point, we're talking about the potentially needing to restart GDMT and the timing of doing that and how it may affect breastfeeding and bonding. We discuss birth control planning. And we have a 2-week, similar to Utah, we have a 2-week post-delivery checkpoint by phone or video, and then a 4 weeks post-delivery, update that echo and EKG or a device check and visit with the team. And we continue to keep that communication open with high-risk OB. So let's check on BG. She's now 30 weeks pregnant, and she has some symptomatic palpitations. She's returned with persistent lower extremity edema and some orthopnea correlating to orthopnic episodes. And so the action here is we do a device check, and there's nothing on this device check, but we remember that she has slow non-sustained VT on telemetry before. So we do a BioTel monitor, which captures slow non-sustained VT. We're unable to start beta blocker due to concerns for small baby size. And so we had decided to admit her. She's 30 weeks pregnant. We decided to admit her, consulting with OB, and we have her in CCU for monitoring. We update her labor and delivery plan to include frequent fetal updates, as well as mom is on bedside telemetry. At this point, there's some decels in baby, and mom continues to have some increasing burden of slow VT. And so we move forward with a successful cesarean at 34 weeks. The consented photo, it's mom and baby. Considering her HCM PEF, or mildly reduced EF cardiac physiology, her pregnancy history, the symptomatic slow non-sustained BT, she was monitored in CCU for 48 hours post-delivery. She required diuretic therapy, but was otherwise stable. And we were able to start GDMT in CCU for her. Partner stayed with baby. Baby was brought to the CCU for bonding. And mom was discharged home with the BioTel device on, so we could be certain to really understand her burden of arrhythmia. In summary here, we have this has been an incredible effort, an experience with the AHA to have the opportunity to model share with centers like the University of Utah. Here's a summary of their pregnancy care plan. And I've learned so much through this partnership. In addition, we have the HCM pregnancy care model, very similar. One of our babies there. And I know we'll be sharing this. We just wanted to thank you so much for the opportunity to share each other's experiences and learn from each other, so we could continue to push forward and improve the care of HCM patients through all different phases of their life, including pregnancy.
Thank you, Heidi, and thank you, Holly, for presenting that case on pregnancy in patients with HCM. We do have a couple questions that we're going to get to from the audience before opening it up to the panel. One of the questions is, given the current laws and the certainties within states being more restrictive, how do you navigate therapeutic abortions given this context?
I can speak from the California perspective. I know, there's a lot of this is a very, it's a tender space. And the earlier, the better in the conversation, the further along the pregnancy, the more complicated things get all around. But the way that we navigate it at Stanford is really trying to be objective about evaluating the risk of mom. Here is the objective evidence that we have here, that is guiding us to be very concerned for mom's life. And then we partner in with high-risk OB so that we are able to really hit the conversation from every angle. And ultimately, we are giving our advice to the patient, and then this is a shared decision-making conversation. Most of our patients, even those who are in the very, very high-risk range, do continue to move forward with their pregnancy, of which we then create a plan to be responsive and vigilant based on their needs and their risk profile. Should we move forward with terminating the pregnancy, there are laws in California that should mom's life be at risk under 22 to 24 weeks. I might have that slightly wrong. We are able to move forward with terminating the pregnancy.
Thank you.
From our standpoint at Utah, to be honest, we partner with our maternal fetal medicine providers, and we haven't progressed with having that conversation. That's more of one that we leave with our maternal fetal medicine providers. So I don't have a lot of experience from that side of things with our side in terms of the cardiac care. We just present our general model, and we get them involved with maternal fetal medicine, and we leave that aspect of things to them.
Thank you for that. We have one more audience question. This actually comes from one of our registrant attendees. How do you educate moms about the signs of sudden cardiac arrest, and how do you identify post-resuscitation care needs in moms and babies during the postpartum timeframe?
So part of our plan, just in general, what we set in place for our patients when they deliver is when they come into the hospital, we have the maternal fetal medicine team page our heart failure team, who's our inpatient team. So that way they are consulting during the entire process. So they come when mom comes in, they consult, and then should anything unwanted from a cardiovascular standpoint occur for mom and baby, our team is already in the loop. Our heart failure doctors also are the cardiovascular ICU attendings So they manage the ICU, they manage our regular heart floor and our consults throughout the hospital. And so with that, if there's anything that needs acute cardiac care throughout the labor and delivery process, the post-delivery process in the hospital, we already have our team consulting and ready, and it is already the ICU attending who is aware of the patient and what's going on.
Thank you. So I'd like to pose this question to the entire panel. We've heard two different approaches during two different times of pregnancy, and we would love to hear insights on other potential methods for navigating HCM care in pregnant patients. Dr. Bhatia, Dr. Wharton, what are some other techniques or methods that you have considered through your models of HCM care during this modern HCM era?
I can go ahead and get started here. So I'm just going to complement the already comprehensive discussion that's already been had here. I think the two other things I think about, we have a lot of patients that I manage that have come over from Cincinnati Children's, relatively young in age. And when, especially the female patients make their way over, family planning is something that we have to discuss. And in my mind, the two things that I'm thinking about are, what is your arrhythmic risk and what degree of obstruction do you have? As well as if there's any sort of other heart failure related components going on. For arrhythmic related risks, just want to be doing a very thorough risk stratification early on. If there's a need for defibrillator placement, it really should be done prior to pregnancy if possible. So we talk about that the first appointment and go from there. From the obstruction standpoint, if these are patients with severe obstruction and requiring high amounts of medication, my go-to overall has been kind of posing, surgical options, including septal myectomy for those refractory patients, as well as myosin inhibitors equally. But unfortunately, in patients being considered that have plans for future pregnancy, we can't use myosin inhibitors. So those are patients that we are more strongly considering some sort of mechanical related intervention, specifically surgical myectomy, for treatment of obstruction early on, so that does not become an issue during the time of their pregnancies.
Thank you.
Yeah. Did you want me to add anything to that?
Do you have anything else to add? Absolutely.
No, I agree with all of that. For patients who don't want myectomy, we can usually in the first couple of trimesters, you can try the addition of Norpace for patients who have severe obstruction. There may be some issues with it going into labor in the third trimester. It's not an ideal situation, but usually between the beta blockers and fluids, you can usually get them through if you have to. Not ideal, but we've done it. Last case we had like that was maybe about 2 months ago. And she's thinking about having another one. So far, so good.
Excellent. Thank you, Dr. Wharton. And thank you, Heidi and Holly, for that great case review. We will actually turn it back over to Dr. Wharton, who will present our last case for this webinar.
Okay, thank you so much. Let me see. Can you see my screen?
Yes.
Okay, so this is a situation I think anyone who's working in academic medicine or a tertiary care medical center is likely to face at some point, just because of the volume of transcatheter aortic valve replacements that are now being done. Transcatheter aortic valve replacement, I believe in the United States, has been going on now for almost 15 years. I think the first cases started around 2010. And it's revolutionized the way we take care of patients with good old-fashioned aortic stenosis. These patients were often referred to the operating room, and many of these patients were high risk for going to the operating room and having a sternotomy. Therefore, there weren't a lot of great options for the treatment of their aortic stenosis, and now there are because the recovery from a TAVR is extremely quick, and usually patients go home the next day. So aortic stenosis has a lot of physiologic concerns associated with it, one of which is left ventricular hypertrophy. And you can see here, this is a patient's TAVR parasternal long axis image here. There's a very, very calcified aortic valve here, commensurate with her age. She's in her early 80s. There is a lot of calcification of the mitral annulus. There is concentric left ventricular hypertrophy, which you would expect in many patients who have long-standing pressure overload on the left ventricle, which is what aortic stenosis is. And she had her TAVR. And when you open up an aortic valve, and I'll see here, this is a scan here. You can see in the pre-TAVR scan, there's a lot of turbulence through the aortic valve, as you would expect. The mitral valve and the mitral annulus is very, very calcified. And you can see that there's some chordal SAM over here. Systolic anti-motion of the mitral chordae. The left ventricle has concentric hypertrophy, as you would expect. Now, the ejection fraction here is good. You can expect that after the aortic valve is opened up, it's going to get better because ejection fraction is an afterload dependent phenomena. And when you bust through this big afterload here, the EF is only going to go up, and that's frequently what happens. So here's her pre-scan here, just before the procedure. And this is immediately after the procedure. And look what's happened. All of a sudden, we have turbulence, but we no longer have turbulence at the level of the aortic valve. We now have turbulence before the aortic valve, somewhere around here. You can see where the color turbulence starts, where the mitral valve might be, say, hitting the septum. And there's also this new jet of mitral regurgitation, which is headed posterolaterally. This is the same patient in the apical 4 chamber just after her TAVR. And you can see here, there is turbulence heading towards the LVOT, right? We don't have the LVOT opened up here because this is a 4 chamber, not a 5 chamber view. And we have this mitral regurgitation jet, which was not previously present, all of a sudden there. And when we do a continuous wave Doppler on her LVOT, what do we see? We now see not a signal of aortic stenosis, which is a mid-peaking jet. We see a late-peaking dagger jet with a velocity of 4.8 meters per second, or a gradient between the peak gradient between the late LV and the aorta of 91 millimeters of mercury. Obviously, ignore these calculations over here. They are not relevant. So what exactly happened here? Patients with aortic stenosis, as we said, have concentric hypertrophy. And when you bust through an aortic valve, the ejection fraction is going to get better. Now, what are the requirements that you need in order to have obstructive hypertrophic cardiomyopathy physiology, or SAM? You need 2 things. Number 1, you need to have hypertrophy of the interventricular septum. And number 2, and you can't predict this all the time a priori, you need to have a redundant mitral valve. You need to have a mitral valve that has enough slack on it so that it can be pushed into the LVOT. Remember, the mechanism of systolic anterior motion of the mitral valve is push. When the mitral valve is sufficiently elastic, again, when it has too much redundancy on it, when there is enough LVH, the flow patterns in the left ventricle change such that the mitral valve is pushed into the LVOT. This was actually described by Mark Sherrod who is now at New York University. At the time, he was at St. Luke's. But this was described in the Journal of the American College of Cardiology almost 25 years ago. So you can imagine that there are some patients with long mitral valves, and they have a lot of LVH, and when their ejection fraction acutely goes up because they no longer have aortic stenosis, they're going to get SAM. Now, in the operating room before TAVR, you could see this happening and deal with it if you had to. Of course, these patients aren't in the operating room anymore. So what can you do in the operating room acutely where they're having or rather in the hybrid room, if you will, where they're having their transcatheter aortic valve replacement? Well, you should have a lot of beta blockers available to be given, if necessary, obviously intravenously, and a lot of fluids. And if the patient were to become hypotensive because of severe LVOT obstruction, you might need something like an alpha agonist, like neosynephrine, which is phenylephrine, in order to support the patient through the procedure. The next day, because her gradients were through the charts, we enrolled her in a program to get treated with a cardiac myosin inhibitor. And this is now what her echoes look like about a month after having started the cardiac myosin inhibitor. You can see there's a TAVR over here. So there's no more turbulence in the aortic valve. And you can see that the mitral regurgitation going back this way and the turbulence in the LVOT is no longer present. And here is her spectral Doppler, continuous wave Doppler with Valsalva in this patient here now being treated with cardiac myosin inhibition. So take home message, now that we're doing TAVRs, you're going to have a lot of patients out there who may be at risk for developing HCM type physiology after the TAVR. So be prepared to deal with it if it happens acutely, and then consider our current treatments for long-term care afterwards. And with that, I'll open it up to questions or comments.
Thank you, Dr. Wharton. We do have a question for the panel and then a couple questions from our audience, or for the panel, excuse me. And I'd like to start with you, Dr. Wharton, and speaking to this and then opening it to the panel. But are there ways to anticipate HCM being unmasked with a TAVR? And if so,
yeah.
how?
Yeah. So sometimes you can anticipate it, sometimes it's going to be a surprise. The harbinger of systolic anterior motion in mitral valve may be chordal SAM. And if the sonographer or the interpreting cardiologist notices that there is mid-cavitary obstruction from mitral valve chordae in the pre-TAVR images, it might tell you or alert you to the fact that this may develop into full-blown SAM after the aortic valve has been opened up. That's been my experience, and the parallel to that would be how we anticipate SAM or LVOT obstruction in patients who actually have HCM, but they are not symptomatic at rest. So you do a resting echo and you see chordal SAM, and they're telling you that they have exercise symptoms. They have no murmur at rest, and they have chordal SAM on their echo. That might be the harbinger to tell you, if they're not previously diagnosed, this is the patient who's going to develop HCM when you put them, when you either Valsalva them or when you exercise them. And those are the patients who you need to provoke further, because as we know from data that's been collected by the HCMA, patients frequently go up to 5 years, between 3 and 5 years between their onset of their symptoms and the diagnosis. And one of the reasons is because LVOT obstruction is a moving target, which is so dependent on loading conditions and afterload, and you can't always figure it out just from a resting exam. So that's the long-winded explanation.
Thank you. We did have a question, a general question with regards to sonography and echocardiographs. Could the panel talk a little bit more about the use of AI in identification, the identification process of HCM?
AI?
Yeah, yes.
Yeah, so it's coming. There are a number of companies that are working on it. There is no, as far as I know, FDA approval for it yet. But you can bet that it is on its way. There is already one company that has an FDA approval to use electrocardiograms, EKGs, to help identify patients who may have hypertrophic cardiomyopathy. So the EKG FDA approval is already in place. The echo, there are a couple of companies, I won't mention names here because I don't want to do anything commercial, that are already working on this platform, and you can probably expect something formally in the next couple of years.
Thank you. Any other panelists would like to comment on the use of AI in the identification process of HCM? Thank you. We do have a few general questions that were submitted through the registrants for this webinar. There was a lot of interest that were related to new treatments and trials for the HCM care space and how it relates to the various populations that were represented here on this webinar. So could our panelists speak to new trials and new treatments for the populations that were represented?
Sure, I'm happy to get started here. And I'm not sure if they perfectly represent each space. These are niche spaces, but so in terms of new trials and spaces, first off, we've talked about myosin inhibitors. Myosin inhibitors, specifically mavacamten, is now FDA approved for the treatment of obstructive symptomatic hypertrophic cardiomyopathy. But that's also being further investigated now for non-obstructive HCM, patients that are not showing signs of blood flow blockages up in the left ventricular outflow tract. So we have 2 trials, Odyssey and Acacia, for mavacamten and aficamten respectively, looking at that. And that's really more to address the heart failure-like features of HCM. In addition to that, there are some for patients that have in the gene space. In my trial, we talked about a patient with myosin binding protein C. There's early phase 1 trials looking at gene therapy in patients, specifically myosin binding protein C, and the role that might play. But that's purely just to look for safety right now. We're years away from anything that's more efficacy focused there. And then finally, there's newer molecules that are coming into the space, myosin modulators, they're being called, in early phase 2 trial. And that's going to be ways of also addressing the overcontractility you see in HCM, but maybe in a way that does not produce as much systolic dysfunction as our current available therapies. So those are some that are on the radar. Another one trial that's coming up is going to be mitotropes, which are medications that really help the heart use energy more efficiently to help improve symptoms. We have a phase 2 trial for that was just completed. And that's a medication called 9-neurofaxstat. And that's going to be looking at phase 3 as well. So a lot of things going on in a lot of different spaces right now. The world is our oyster for HCM trials.
Yeah, I would echo that. It's a very, very exciting time with all the new molecules that are coming out, not just for improvement of systolic function as mentioned, but also improved lusitropes, making the heart relax better. And the fascinating thing about that is that if the positive lusitropes work for these patients, there's no reason to say that it's necessarily restricted just to patients who have hypertrophic cardiomyopathy. There's a lot of diastolic heart failure there. It's the endpoint of a lot of different pathologies. So, as a former vice president once said at the end of one of his speeches, quote unquote, "The future will be better tomorrow."
And as all of this innovation hits practice, in May, the AHA HCM update to the guidelines includes mavacamten as a class 1 recommendation. So in addition to being FDA approved, it's also a class 1 recommendation now in the guidelines for treating obstructive HCM.
Mm-hmm. Yeah, I'll mention one more thing just because it came up. We partook, there might have been other sites here as well that are represented. We participated in the Odyssey HCM trial. The trial is still going on, but new enrollments are closed because the trial met its quota of 420 patients. What was very encouraging was that in the middle of the trial, the protocol was changed such that after 48 weeks, it went from a double-blind placebo-controlled trial to everybody getting open label mavacamten. Clearly, the Data and Monitoring Safety Board could not have justified having done that, which means they could not have justified that without saying we can no longer justify continuing a placebo arm. So even though we're not going to have hard results on this trial, probably for at least another year, the fact that they did that is very, very encouraging.
Thank you.
And what I would encourage to all the practitioners on the phone is that, as Heidi mentioned, mavacamten is now in the guidelines, but the guidelines and standard of care are going to be changing rapidly in the coming years. And for right now, standard of care is still inadequate for treating our patients. So a big part of that is if you have a patient that's ongoing symptomatic despite medical therapy, consider referral for a clinical trial or to a center that can, because I've been telling patients clinical trials are becoming part of the offerings of standard of care right now, because that's just the phase that we're in this space.
really good point.
That actually covered one of the questions that came from our audience, which is how do you navigate the affordability of myosin inhibitors for some of your patients with HCM, which leads to the conversation about the clinical trials. We did have one additional question that we would like to pose to each one of our panelists for the conclusion of this webinar is, because this is a case study review with clinical insights, we would like to take a moment to hear your clinical insights through this case study review and the last thoughts that you would like to leave with our audience as a point of care or a point of consideration when treating HCM patients. So your last thought that you would like to leave with our audience members as it relates to considerations for caring for these patients with HCM.
I can go there. So my last thoughts, great question, would be this is an exciting time for treating the HCM patient. There are so many new innovations and treatment options. I think still remembering that HCM is different in every individual. So making sure to partner with your patient and their care team to really understand what this HCM heart needs, and then include in the options for creating your care plan for this patient, clinical trials, novel therapeutics, and traditional interventions as well. But just that continued partnership and just being responsive to the individual HCM patient.
As I take care of HCM patients, the biggest thing that I'm reminded of every day with them is that education is so important in the process of taking care of these patients. I'm a firm believer in that the more a patient understands their own diagnosis and their own health, the better that they are then able to have the skills to take care of their life and what they need to do. So I feel like education is a huge part of that. And as things change with our new clinical trials and things that become available in our research and we learn more about the disease, that education process changes. And so following these patients throughout their lifespan, not just seeing them once and letting them go, right? This is a lifelong disease that changes, and having that opportunity to educate them and work with them and ask them what their questions are and what they've heard in the community and be able to, talk through all of those things is so key in taking care of these patients.
You can go, Ankit.
Okay. What I'd say here is seek a diagnosis. It's easy as us as cardiology practitioners to treat AFib. Easy for us to go cath anyone that has a trope elevation. Ask the why it's happening. Don't just call everyone HFpEF for type 2 and STEMI. And once you do find and establish a diagnosis of HCM, treat the myocardium, and as opposed to the downstream consequences of it, and take that approach, an HCM-centered approach to your care.
Yeah, it's an exciting time, like everyone said. After 6 decades since this condition was first identified by Eugene Braunwald and Andy Morrow in the very early 1960s, we finally have agents that are actually designed to treat it. Because for the first 60 years of treating this, we were all using medications that were repurposed from other conditions with modest benefits at the cost of side effects and the need often to have invasive procedures because the medical therapies didn't work. That paradigm now has completely changed. We have tailored therapies that are specifically designed for this condition, and we're actually showing in many ways that we are remodeling the heart. The heart's becoming less thick. The diastolic function is improving. Often the degree of mitral regurgitation is improving. The patients feel better. Their quality of life, as measured by an objective standard, is going up dramatically. And this is just the beginning. So, this is, if any of you out there in the audience saw A Man Called Otto with Tom Hanks, That was filmed in the, I think, to be taken around the time of the early 1960s. He didn't do so well in the movie. He died at the end of the movie, and he had HCM. That was part of the plot. It's not like that anymore. It's a different world. So it's a good time to be practicing in this arena.
Thank you. Thank you, Dr. Bhatia, Dr. Wharton, Heidi, and Holly for leading today's webinar. Again, we will also want to thank you for your participation in today's event. After today's webinar, you will receive a follow-up email with a survey on the presentation, and we would appreciate it if you would complete that and provide your feedback. On behalf of the American Heart Association, thank you for joining us and have a great day. This concludes today's presentation.